Okay, I have live stream பண்ணிட்டேன்டா.
Okay, thank you.
Just join after this patient, yeah?
Yeah, sure. Can you
Yeah.
make Dr. Aisha's host?
I will make you as a host so that you can be, you can also give everybody as co-host கொடுத்துருங்க. Okay, so ஒன்னுங்க பேர் HP guest இல்லையா? அதில் I'm making as your host.
Yeah.
Change host. Okay, so now here afterwards you will be the host, okay? And
Okay.
Aisha madam, I'm making her as the co-host, okay?
Okay, fine.
Oh no, I cannot make it now. You can make it. You can
Okay.
make all the speakers as co-host.
Okay.
Just go click near Aisha and you will have the 3 points. இருக்கும்.
You are the host நவன் வந்து அதுக்கு
yes and click பண்ணிடுங்க. Yes and click பண்ணுங்க.
அது ஒண்ணுமே வரலையே அதுல.
இல்லம்மா participants ஓட click
Yeah,
பண்ணுங்க.
yeah, கீழ இருக்கு.
click பண்ணீங்கன்னா participant ஓட list open up ஆகும். ஐயோ நான் தெரியாம
நீங்க I don't
என்னன்னா இப்போ நோ ப்ராப்ளம்டா ஜஸ்ட் ஓபன் அப் தி பார்ட்டிசிபென்ட்ஸ் லிஸ்ட் ஓபன் பண்ணுங்க.
Yes.
ஓகே ஆயிஷா மேடம் நேம் இருக்கா?
HP லேப்டாப் ஹோஸ்ட் தான் வருது மேம். நீங்க ஹோஸ்ட்
HP தான், இவங்க தான் ஹோஸ்ட். HP வந்து தனலட்சுமி இஸ் தி ஹோஸ்ட்.
அதுக்கு மேல எப்படி எனக்கு கோ-ஹோஸ்ட் ஆக்குறேன்னு தெரியலையே.
ஐயோ இல்லப்பா பார்ட்டிசிபென்ட்ஸோட லிஸ்ட் கிளிக் பண்ணுப்பா. கீழ பார்ட்டிசிபென்ட்ஸ்
எஸ்
லிஸ்ட் ஓபன் அப் ஆயிடுச்சா சைடுல? அங்க டாக்டர் ஆயிஷா மரியம்னு இருக்கா?
யா
அது பக்கத்துல கோ அண்ட் கிளிக் ஒரு 3 பாயிண்ட்ஸ் இருக்கா?
கண்டுபிடிச்சிட்டேன்.
கண்டுபிடிச்சிட்டியா? மேக் கோ ஹோஸ்ட்.
Yeah, sure.
Yeah, like that you can make everybody, Ramesh and Vignesh, எல்லாரையும் நீங்க co-host ஆக்கிடலாம். Got it?
Yes. I'm doing Ramesh, Aisha, Vignesh.
Swapna, ma'am.
Yeah. Swapna, Ashwati and one more.
Srivatsal. They're joining. They're to join, I think. Vignesh, call Ashwati.
Whomever is presenting அவங்கள மட்டும் co-host ஆக்கினா போதும்பா.
Okay.
Yes, ma'am. You made us, ma'am?
Yeah, you she has made you இன்னும் கெஸ்ட்ல தான் இருக்குப்பா.
Aisha
HP மட்டும் தான் ஹோஸ்ட் இருக்கு.
நீ co-host கிளிக் கொடுத்துட்டேன். அதுக்கு அப்புறம் ஏதா பண்ணனுமா?
ஒண்ணும் இல்ல.
நீங்க co-host கிளிக் பண்ணிட்டேனே. I think நீங்களே பண்ணிரலாம்னு நினைக்கிறேன்.
அப்ப என்ன திருப்பி ஹோஸ்ட் ஆக்குங்க அப்போ. என்னோடல போய் கிளிக் பண்ணுங்க IAP TNSC ல.
ஒரு நிமிஷம். நான் கிளிக் பண்றேன். நான் மேக் co-host போடுறேன் but nothing is happening.
சரி நீங்க என்ன ஹோஸ்ட் ஆக்குங்க நான் பண்ணிடுறேன்.
அதுதான் ஓகே.
I will reclaim my host, don't worry.
Okay.
Now I did it. Don't worry. I will make Arun as the host. After making that will be easy. Make host Aisha and confirm. Okay. And where யாருக்கு விஷயம் நான் பண்ணிட்டேன்.
Actually only Aisha is going to share the slides.
Then fine. அப்போ ரெண்டு பேரை பண்ணிட்டேன். Now I will make Arun as the host. என்ன Arun?
Okay ma'am.
So you will be able to manage. Yes. Done. Okay pa. I think even YouTube is live. So
yeah.
Can you see the slides?
Good evening.
Good evening.
Aisha, you cannot see your slides, Aisha.
Good evening, sir.
Yeah,
Good evening, Dana. Good evening, Murugesh.
Good evening, sir.
Good evening.
SPS sir, good evening. Sir is there.
Yes, sir. Thank you.
Good evening.
Hello everyone.
Sir, good evening, sir.
Sir, good evening, sir.
Roms,
Good
Dana,
evening, sir.
Mahesh, Aisha, Arun,
Hi, sir.
Good
Can you
evening,
see the
Mahesh sir.
slides?
Good evening. Yeah.
Yeah. We are able to see. So I think you can start Murugesh Lakshman.
Yes, ma'am. Shall we start now?
Yeah. 9 o'clock. Start.
Okay. Good evening, sir. Good evening, madam. So, welcome you all for this month's program by Pediatric Infectious Academy, Tamil Nadu chapter. This month, we will have a specialty series concentrating on our challenging CNS infections in children. Last month, actually, we had concentrated on general pediatrics. So this month, we thought we'll do a specialty series with concentrating on CNS infections. So welcome you all to this program. At the outset, we will start the program with the pediatrician's prayer. I request Dr. Arun Vikraman to deliver the IAP TNSC prayer.
Good evening, all.
Arun?
Good evening, all. Pediatrician, am I audible, sir?
Yes, sir.
Yes, you're audible.
Pediatrician prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate sufferings. May we be emissaries of health, learning, charity, love, and peace to all the children and their families, irrespective of their status and creed. Give us the wisdom, understanding to change things we can, retain the good and accept within the reasons the thing we cannot change. Grant us blessings, grace, and mercy in all situations, at all times, and amidst of all people. Thank you. In Tamil, yes, sir. எங்களுக்கு முழுமையான குணமளிக்கும் திறன்.
One is enough, Arun.
Okay, sir.
Okay. Next, I invite Dr. Soundsundara, sir, IAP TNSC president, to deliver a few words.
Yeah, thank you, Dr. Murikesh. So, respected office bearers of PIDA, Dr. Dana, Dr. Murugesh, and Dr. Arun, and our own team of IAP TNSC, our secretary, Dr. Narmada, our EB member, Dr. Jalil is there, and the respected faculties on the platform, Dr. SPS sir, Dr. Magesh sir, Dr. Janani madam is also there, and all the faculties for today and the postgraduates. So a warm good evening to you all from IAP TNSC. So we started the year with a subspecialty one specialty 1 month, and very happy that this ID chapter took over the first CME, and that was a mega hit CME, and YouTube views are increasing day by day. So as a continuum, this CME is a sole CME of the chapter itself, and great to be at the inaugural part of the CME. So wish we will have more and more CMEs from the infectious chapter, and we know that we all are heading towards the May month program, that is the 23-24, the midterm CME also, which is from PIDA, and we all know bread and butter of pediatrics is infection. So definitely this all will be useful for all the pediatricians, wherever they are practicing. And hats off to the organizers for a great event, and welcome you all to register for the Golden Jubilee Chennai Pedicon. We are all waiting for the annual mega event. So welcome you all. Thanks for the invite, and happy to be part of this. Thank you.
Thank you very much, sir.
Yeah.
Next, I call upon our secretary, Dr. Narmada madam, to say a few words.
Thank you so much. As usual, a very vibrant chapter under the chairmanship of Dr. Dhanalakshmi, Dr. Murugesh Lakshman, and Arun Vikraman, ably guided by Dr. Balasubramaniam. The PIDA of Tamil Nadu has always been in the forefront and has been one of the very pioneering subspecialty chapters for the past 3 years. And again, we are going to conduct our midterm PIDA also, and we have got a lot of, we are getting registration. So I request everyone to kindly register. And today, Dana is always very concentrated on each of the specialty, and today she has put a very interesting topic on challenging CNS infection in children. Very beautifully curated, and we have the experts from Dr. Ramesh, Dr. Mahesh, Dr. Gopinath, and we have also heard to Dr. Aisha multiple times in our series. So we are very happy to have the panel, and I really wish PIDA subspecialty chapter a grand success of this program as well as the upcoming program. And thank you for asking asking me to be associated. Thank you.
Thank you, madam. So without wasting much time, we will go into a session. I request our chairperson, Dr. Dhanlakshmi madam, to introduce the panelists and presenters, and we will start discussion. Over to Dhanlakshmi madam.
Very good evening, dear all. On behalf of TIDA Chapter Tamil Nadu, I welcome you all for the CME. And I'm truly thankful to the TNSC chapter for always helping us. Whenever we ask anything, they're immediately there to help us. And it's a great privilege to welcome my mentors, Dr. SBS Sir, Janni Ma'am, who always guided us and supported us in all the ways. And last couple of months, we had interesting CNS infections where we faced challenges in diagnosis and in some cases, we face challenges in treatment. So we thought we'll share our experiences.
இது நம்ம ஆர்த்தோட்ட தான்ப்பா ஆர்த்தோ போனீங்களே அவர் என்ன சொன்னாரு எக்ஸசைஸ்லாம் சொன்னாரா
Arun, please mute everybody.
So that's when we thought we
Nana, you can unmute yourself. You are muted. Yeah.
So this month we thought we will present our interesting CNS infections cases, and we have enthusiastic postgraduates, Dr. Ashwati, Dr. Swapna, Dr. Vignesh, and Dr. Srivatsan, and ably guided by Dr. Aisha. She is an young and energetic junior consultant in pediatric neurology. And we have experts to guide the session, Dr. Ramesh, who is a pediatric ID consultant from Coimbatore, and Dr. Mahesh, who is a pediatric neurologist, and Dr. Gopinath, consultant radiologist. So over to Dr. Aisha, please proceed. Aisha, you are muted.
Aisha ma'am, kindly unmute yourself, ma'am.
Yeah,
You're audible now, ma'am.
yeah, 1 second. A very good evening to everybody. I would like to begin by thanking the organizing team for giving us this opportunity to moderate this very interesting session today. Today we will be discussing 5 important and thought-provoking cases that we have encountered in our practice over the past few months. As we all know, neuroinfections pose a very significant diagnostic as well as therapeutic challenge. Through this session, we hope to share these experiences, discuss the reasoning behind the management strategies that was used, and highlight some important clinical pearls that may help us approach very similar situations in the future. Without much delay, I would like to invite our first speaker for the evening, Dr. Ashwati, who will be presenting a rare and challenging case of complicated pneumococcal meningitis. Dr. Ashwati, over to you.
Thank you. Shall I start?
Yeah.
Good evening, everyone. So today I'll be discussing a case of complicated meningitis, which progressed from an infection to infarction. So this was a 11-month-old preterm infant who was born, second born to a non-consanguineous early married parents with a birth weight of 1.47 kgs. She was currently thriving well with a weight of 7.9 kgs, immunized up to date according to the national immunization schedule and developmentally appropriate. She presented with complaints of fever for 5 days, vomiting and refusal of feeds for 1 day. With a progressive...
அது இந்த கொப்பரி பாம்பு மாதிரி இருக்கு, அதுக்கு மருந்து போட்டீங்கன்னா கொஞ்சம் ரொம்ப வராமல் இருக்கும். அந்த சிறப்பு எழுதியிருக்கேன், அதை வாங்கி கொடுக்க சொல்லணும் ஒரு 5 நாளைக்கு.
With increasing lethargy and progressive worsening of sensorium. So at presentation in the ER, her GCS was 13/15, her AFS is level, and she had features suggestive of compensated shock. So the initial workup in the ER revealed anemia with leukopenia, total count of 1,700, with thrombocytopenia, the platelets of 40,000, with a deranged coagulation profile. Her INR was 2.2 and APTT was prolonged. Her CRP was elevated, and she also had features of metabolic acidosis. So at this point, with diagnosis of acute meningoencephalitis of bacterial, viral, or rickettsial etiology was in our minds, and the initial management of this child, she was empirically started on injection ceftriaxone, vancomycin, doxycycline, and acyclovir after sending blood cultures. She was also started on injection dexamethasone to reduce the CNS inflammatory response. CSF analysis was deferred at this juncture because of the deranged coagulation profile and thrombocytopenia. And we proceeded with the neuroimaging. The MRA showed features suggestive of bacterial meningitis with bilateral frontal subdural effusion.
I would now like to invite Dr. Ramesh for our first question for today. Dr. Ramesh, could you please discuss the rationale of vancomycin as empirical therapy in a child with acute meningoencephalitis? Also, when do we consider starting acyclovir, doxycycline in these cases?
So, good evening, everyone. At the outset, I would like to thank our IAP Tamil Nadu chapter and PIDA chapter and Dr. Dhanalakshmi ma'am for having us here, and happy to be a part of this interesting session of learning. So, coming to this case, what is the rationale of vancomycin as empirical therapy in acute meningoencephalitis? So, in a child presenting with the syndrome of acute meningoencephalitis, obviously, among the infective causes, the possibilities that should be considered would be viral and bacterial. So, among bacterial, we know that Streptococcus pneumoniae is the commonest cause. And when we see the evidence of adding vancomycin, it is such that when we see the Streptococcus pneumonia isolates causing pneumonia, as such, only community-acquired pneumonia, the rates of ceftriaxone resistance are very less than 1%. So, but whereas in a child with meningitis due to Streptococcus pneumonia, as per the recent ICMR data and our studies done, especially in the southern part of India, the rates of ceftriaxone resistant Streptococcus pneumococci are around maybe 12 to 15%. So, in a child with a syndrome of acute meningoencephalitis, which is a severe and invasive infection, our target attainment with the empirical therapy should be 100%. So in this scenario, it would be prudent with an rate of around 12 to 15% of ceftriaxone resistant pneumococci. It would be prudent to add vancomycin in addition to ceftriaxone to cover Streptococcus pneumoniae especially. And regarding the second question, when do we start acyclovir? So as told earlier, apart from bacterial causes, there are certain viral causes which are commonest etiology for acute meningoencephalitis. That would be enteroviral, dengue encephalitis, and all those things. One other important cause which is treatable, which viral infection has a treatment, is HSV. So, as said earlier, because of the severity of infection, until we have a definite imaging or CSF evidence of an alternative etiology, it is also equally important to add acyclovir. Also, in this case, doxycycline was also added, which is equally important, especially with the leukopenia and thrombocytopenia. Because in our part of Tamil Nadu or even southern part of India, especially when there is a monsoon season, it is equally important to cover atypical, including scrub.
Thank you, sir. Let's proceed.
So these were the initial MRA findings, which showed leptomeningitis with subarachnoid exudates, patchy cortical involvement, and arteritis changes in the right MCA, and bilateral frontal subdural effusion. So a neurological consult was also obtained at this point and advised conservative management. So the blood culture that was sent initially showed growth of Streptococcus pneumoniae. The sensitivity report for the same showed cephalosporin resistant strain of pneumococci, which was sensitive to linezolid, levofloxacin, and vancomycin. So with this sensitivity report in mind, the ceftriaxone and vancomycin was continued and acyclovir and doxycycline were stopped. So following the third dose of vancomycin, the trough level monitoring was done and it was found to be low with while the child was on a maximum dose of 70 mg per kg. And there were also concerns of decreased urine output and evolving AKI with the serum creatinine ranging from 0.3 to 0.4. And she also continued to have the same sensorium with no further clinical improvement. So at this juncture, we needed a modification in the therapy.
At this junction, I would again like to invite Dr. Ramesh to share his thoughts on monitoring trough levels for vancomycin? Specifically, what is your approach in measuring vancomycin trough levels? Also, how would you modify therapy? And what would be the next antibiotic that you would consider
So
in such
regarding the
patients?
yes, ma'am. So regarding the first question, what is your take on vancomycin trough level? So routinely in our center, we are not doing vancomycin trough level as such, but as per the evidence, the indications of doing vancomycin trough level in a child with especially strep pneumonia meningitis would be when there is a associated renal dysfunction or when there is concerns of decreased urine output or when there is a poor clinical response. So, regarding the take on vancomycin trough level, nowadays, based on evidence, especially from MRSA bacteremia in children or adults treated with vancomycin, they have moved away from trough level monitoring to with something called as area under concentration time curve by MIC. It is a better predictor of clinical efficacy and they have a less risk of nephrotoxicity. So considering that, also we should also equally check the lab in which we are doing. It should be a proper lab, and the trough levels should be, or the AUC by MIC level should be properly interpreted. So if there is a trough level available, as I told earlier, those are the indications in this child when we should consider trough level. So and in our case, since we have done a trough level already, and the ideal trough level would be around 10 to 15. More than 15, there is risk of nephrotoxicity. Here, regarding the second question, how would you proceed? So, in a child with ceftriaxone resistant strep pneumonia meningitis, who has been already on more than 48 to 72 hours of vancomycin with a low trough level, while on a maximum dose, if there is no clinical response, especially with persistent fever and no improvement in sensorium, first thing which we should look for is the source control. If there is any worsening subdural empyema, then it should be drained. As told earlier, I think the subdural empyema was very less, which could not be drained. So in this scenario, other thing would be modifying the medical management. So since there is no proper clinical response with vancomycin, I would still consider vancomycin. But as per the evidence, if there is no clinical response on vancomycin, the other option would be adding rifampicin. But especially with the low trough levels, we can't add rifampicin as a monotherapy in this situation. So other options would be either linezolid or levofloxacin. So levofloxacin and linezolid, there are no head-to-head trials when comparing both. But considering the excellent CNS penetration of linezolid, also with an better evidence, so for robust evidence for linezolid, and better clinical like in vitro activity of linezolid towards strep pneumoniae, linezolid would be a little more preferable than levofloxacin. So I think it is okay to add linezolid initially.
Okay, sir. Thank you, sir. Thank you.
Here we have added injection linezolid along with vancomycin because the child was on NG feeds and we had concerns regarding the absorption of oral rifampicin while being administered through the NG. And however, despite the therapy, the patient continued to deteriorate neurologically. She developed recurrent focal seizures involving the right side, which progressed to refractory status epilepticus, requiring intubation and continuous sedation. She also had new onset fever spikes and an increase in the total counts and progressively increasing inflammatory markers. So at this point, a CT was repeated and it showed multiple acute infarcts in the cortex and white matter and the right gangliocapsular regions.
I would now like to invite Dr. Gopinath, sir, about talking about how common these complications are in bacterial infections.
So are you able to hear me?
Yes, sir.
Okay. So the present images. So the images present the CT axial and coronal sagittal reconstructed images. So the high frontoparietal cortex showing there is a hypodense areas and it not only hypodense, and the entire brain parenchyma in this location is also appears to be liquefied. So it's a form of acute laminar cortical necrosis. So it's this could be due to ischemia or extensive inflammation or extensive virulent infection directly. It's also can produce all those things. So all the parameters can cause this kind of cortical laminar necrosis. This is a irreversible conditions. So the patient will always present with a significant sequelae. So we know that this is a very, very rare complication of pneumococcal meningitis. This is the acute cortical laminar necrosis. Okay. So if you see these images, it is not confining to any vascular territory. So both the anterior cerebral artery and the middle cerebral artery territories are involved. And also you can see some areas of the posterior fossa also involvement also present in this case. So other complications like in this case, we have seen the subdural empyema, we have seen, and sometimes intraparenchymal abscess. If it is involved the vessels, we can get a vascular territorial infarcts will be there. And if you see other things, the venous sinus thrombosis. So these are all the signs of these complications of bacterial meningitis.
Thank
So
you,
this
sir.
is case is acute laminar cortical necrosis.
Okay.
So irreversible condition.
Okay, sir. Thank you,
Okay.
sir.
Thank you. So due to the clinical and radiological deterioration, antibiotics were further escalated. Vancomycin was stopped in view of clinical worsening, and we added levofloxacin and rifampicin, and injection linezolid was continued. So coming to the antibiotic timeline of this patient, on day 1, she was empirically started on injection ceftriaxone and vancomycin with MRA suggestive of bacterial meningitis with a culture growing ceftriaxone-resistant pneumococci with leukopenia, thrombocytopenia, and elevated inflammatory markers. On day 4, with concerns of low vancomycin trough levels and an evolving AKI, and having reached the maximum dose of vancomycin, while her total counts were continuously rising and the thrombocytopenia persisted with no improvement in the clinical response. Injection linezolid was added along with injection vancomycin. And following further clinical worsening of persistent fever spikes, increasing inflammatory markers, and total counts with the refractory status epilepticus, we had to stop injection vancomycin, add levofloxacin and oral rifampicin, and continue linezolid. At this point, we also got a neurosurgical opinion, and in view of the increasing subdural collection, she underwent a burr-hole craniotomy for the drainage of the same. The gram stain showed few pustles, and the culture from this showed no growth. Her sensorium gradually improved following the procedure. So seizures were eventually controlled, sedation infusions were tapered and stopped, and the repeat blood and CSF cultures were sterile. An immunodeficiency workup was also done, which was negative. She completed 6 weeks of antibiotics, and at discharge, she was active, alert, and tolerated oral feeds well. She was hemodynamically stable. She was discharged on maintenance anti-epilepticus with planned neurological follow-up. So coming to the recent ICMR antimicrobial resistance surveillance report, susceptibility of Streptococcus pneumoniae, as already Sir mentioned already, to penicillin in meningeal isolate is quite high, and it supports the use of empirical combination therapy of ceftriaxone and vancomycin. We also have a similar study from our center, which has showed penicillin and cephalosporin resistance of 6% amongst the meningeal isolates. So the current treatment protocol for pneumococcal meningitis, for penicillin-sensitive strains, it would be the choice of antibiotic would be ceftriaxone at a dose of 100 mg per kg per day in 2 divided doses, or cefotaxime. In strains that are resistant to penicillin and sensitive to ceftriaxone, we could use ceftriaxone or cefotaxime in the dose mentioned. And in strains that are resistant to both penicillin and ceftriaxone, intermediate or resistant to ceftriaxone, a combination therapy of ceftriaxone with vancomycin at a dose of 60 to 80 mg per kg per day is considered. So the take-home points.
Thank you, Ashwati, for that insightful presentation. I will shortly add some take-home points. Generally, pneumococcal meningitis is complicated with cerebral vasculitis and infarction. So keep a high threshold. If we have worsening neurological symptoms, always repeat a neuroimaging to see if they've gone into some complications. There is a significant proportion of penicillin and ceftriaxone resistance that is seen among the meningeal isolates of pneumococci, and antibiotic resistance significantly impacts management. I would now request Dr. Dhanalakshmi to kindly take over for the question and answer session for this case.
Gopinath sir, I have one doubt. So regarding this repeat imaging, hello?
Yes, ma'am, you're audible.
Yeah,
You're
sir.
audible.
Yes, sir is there? No. Okay. Sir, SBS, sir? Hello?
Yeah. Tell me.
Any inputs you want to give?
I want to know the vaccination status of this child. One.
Child is vaccinated with pneumococcus.
No, vaccinate. What vaccine was given? That is number one. Second, did you send this to CMC for typing of the pneumococcus?
Sir, now they are part of one more study, sir, the McLean study.
No. Did you get the strain? Did you get
No,
the...
sir. Like they were doing batches. We have sent for serotyping, but yet to receive the reports, sir.
Okay, that is number two. Third, throughout the world, if you see the recent literature on pneumococcal meningitis, the whole world is moving from linezolid to levofloxacin. Dhanalakshmi will always say, I have a bias for levofloxacin. In fact, I read a recent article where they recommend levofloxacin as a superior drug to vancomycin in penicillin-resistant and ceftriaxone-resistant pneumococcal meningitis. I'm sure Dhanalakshmi would change from vancomycin to levofloxacin straight away for the next case of pneumococcal meningitis. In this case, who had a hemoglobin of 6.4, low platelet count, I would not have given linezolid, and I would have upfront given both rifampicin and levofloxacin to this child, and would have stopped vancomycin very early once it is not working, or I might have continued all the three. That is my comment number one. Comment number two, I would like to know what vaccine was given and what is the strain. And they report that some strains, I'm bad at numbers. Some strains like 19A, 19F, they are notorious for not only parapneumonic effusions, but also for this sort of crazy meningitis where you start treatment very early, still things go on. The last comment is, a new thing is appearing in pneumococcal meningitis and also in tuberculous meningitis. Again, there is a recent review and a meta-analysis of steroids. So they say even in pneumococcal meningitis, the pendulum is swinging back towards using steroids upfront, beginning. One. Two, a new approach to the management. In those cases like this, which progress in spite of, good antibiotics, in spite of, in vitro sensitivity, your drugs are not working. In addition to steroids, few cases of TB meningitis as well as pyogenic meningitis, the modern thinking is to give rituximab. Few studies are emerging. That's going to be the future. These are my comments. Thank you. Excellent presentation.
Regarding the vaccination status, this child received pneumocins, a government vaccination schedule. And the next thing is, we also had a debate about whether to add levofloxacin or linezolid. But head to head, they say the CNS penetration wise, linezolid is slightly better. But I agree, there are no direct comparison in penicillin resistant isolates of pneumococcus, whether which one is superior. So linezolid or levofloxacin. And regarding when there is cytopenia, whether we can give linezolid, when there is a bone marrow suppression due to some other cause, then ideally we should not start. But this is a sepsis-induced bone marrow suppression. If it is only a drug of choice, definitely we can add. And after adding linezolid, counts improved only. There was no suppression. But first line, whether linezolid or levofloxacin is always a debate only, sir. So maybe we can. So this child vancomycin MIC was only 0.5. That is the reason we continued. So it may help. Then after 4 days, definitely it was not helping. That's where we stopped and we switched to all the 3 alternative drugs, linezolid, levofloxacin, and rifampicin. Fortunately, neurologically also this child recovered very well, except there was a slight left-sided hemiparesis. Rest of the parameters were improving.
Okay.
And immunodeficiency workup was totally negative, sir.
What was the MIC for levofloxacin and linezolid in the lab?
Linezolid, they always mention 2 only, sir. And the breakpoint also they mention 2. So everything they will not report less than 2 only. So based on MIC breakpoint, we cannot comment whether it is superior. We cannot compare with the levofloxacin MIC.
Okay. One other comment. One of the important, of course, this I'm sure you would have done it. One of the important points for a general pediatrician to remember: routine meningitis, penicillin sensitive, ceftriaxone sensitive, clinical improvement, no need to repeat LP. Any penicillin, ceftriaxone resistant meningitis where you use vancomycin, and repeat LP to make sure the CSF has become sterile is mandatory. Like HSV infection, where you have to prove that the PCR is negative, in pneumococcal meningitis, you have to repeat the lumbar puncture and ensure it is sterile. I'm sure you would have done it. Even if you had not done it that way, you would have collected fluid from the subdural space from the neurosurgeons.
The first time
Make
you're not
sure
able.
it's not pneumococcus. I know the message for pediatrician.
Yeah, definitely,
You
sir.
have to repeat a lumbar puncture once there is a thing. And last comment, the Dr. Balaji's first study, which has shown that there is a lot of ceftriaxone and penicillin resistance in India. They showed in CMC 40% adult children, their resistance rates were 40%. Of course, in fact, I still remember in one of the NCPIDs when I talked about this article and said that we must give vancomycin, they all jumped on me. No, ceftriaxone in Delhi, we don't see resistance. Okay. Now it took some time for them to accept. Now you have to give. I mean, the general microbiological principle is that if in any life-threatening infection where you have a high target attainment ratio, you should have a target attainment rate very high. You have to, if the resistance rates in the community exceeds 10%, you have to go for the second line. And in India, it has crossed 10% very long ago. Now it's hovering around 40%, which is frighteningly high.
Definitely, empirically, we need to start on vancomycin along with ceftriaxone till we get the organism ID and sensitivity. That should be the take home. That Aisha, can we move on to the next presentation?
Yes, ma'am.
Janni ma'am is there. It's her case, ma'am. Janni ma'am. Okay. Aisha, move on to the next presentation.
Yeah, let us now move on to the next presentation. We now have Dr. Swapna presenting a very interesting case of brainstem encephalitis.
Dana, I'm there. Yeah.
Sorry, ma'am.
Yeah, Dana, this child is doing.
Yeah.
Yeah, I know. This child is doing really well on follow-up. There is no sequelae. Child's hearing is also normal. And I think even 2 days back, the child came to the OP and child is doing well.
Thank you.
Thank you, ma'am. Let us now move on to the next presentation. We have Dr. Swapna, who will be presenting a very interesting case of brainstem encephalitis. Dr. Swapna, please proceed with your presentation.
Yes, ma'am. Good evening, one and all. Today, I'll be taking you through the management of a child who presented with encephalitis, but finally unraveling quite a rare infection. So this is a 12-year-old girl who was previously developmentally normal and immunized up to age. She presented with fever and neck pain for the past 7 days, and which progressed to headache, vomiting, inability to close her right eye with diplopia, and labored breathing for the last day. So she was started on intravenous antibiotics and oxygen in view of desaturation and referred to a higher center. And at admission at the referral hospital, she had one episode of right focal seizures. She was tachycardic with poor perfusion, but normal BP. She was in a state of compensated shock with GCS of 9/15, and her pupils were bilaterally equal and reacting to light. She had lower cranial nerve palsy, right element facial palsy and 9th and 10th nerve palsy with Koenig sign positive and no other focal neurological deficits. She also had a gallop rhythm noted and she was in respiratory failure. Next slide, please. At this point, the diagnosis of acute encephalitis with lower cranial nerve involvement with respiratory failure and possible aspiration pneumonia and myocarditis was considered. She was intubated and started on inotropes. Her initial CT brain was normal and CSF analysis showed pleocytosis with normal protein and glucose and sterile culture. The meningoencephalitis panel also was negative. She was started on injection piptas, vancomycin, doxycycline and acyclovir. And her infective etiology workup at this point, CRP and procalcitonin were mildly elevated, and scrub and dengue serology were negative. Malaria card test was negative. Blood culture and CSF cultures were sterile. So at this point, she was referred to us on day 9 of illness in view of persistent lower cranial nerve palsy and ARDS. At this point, her GCS was normal. She had moderate cardiac dysfunction with ejection fraction of 35%, and her pneumonia was improving with minimal ventilatory settings. Next slide, please. So at this point, her encephalitis was improving. She was diagnosed with acute encephalitis syndrome, which was improving with lower cranial nerve palsy, myocarditis, and aspiration pneumonia.
I would like to invite Dr. Mahesh to discuss the possible differentials that should be considered in this clinical scenario.
Good evening, all. So, this is a child with acute encephalitic syndrome with the lower cranial nerve palsy. The structures involved, see, the optic nerve is back because the pupils are reacting to light. So, predominantly, the lower cranial nerves are involved with we may neck stiffness, and we want to know that status of the brainstem also. Then, with the myocarditis, pneumonia, we may consider as aspiration or we may consider as a pneumonia. So there are the few possibilities. One thing is if the posterior fossa structures are involved, brainstem is involved, we call it as a rhombencephalitis, which is more commonly involved in enterovirus infections. And sometimes if pneumonia precedes, we can consider the mycoplasma also. These are the infective causes. Sometimes borreliosis can cause, listeria can cause these type of infections. So rarely, sometimes we may find myocarditis with this type of involvement in diphtheritic infection also. And an inflammation, any ADEM with brainstem involvement may present like it, but the child had a neck stiffness, fever and all, we have to be cautious. And rarely this MOG encephalomyelitis can present as PUO like illness, but with this type of cell count and infected excess, I will not think of that now. So there is a possibility of infection, probably a viral or bacterial infection, we may not know right now, with predilection for myocarditis. And then at this stage, we may not know that child had a status and then had a cardiac arrest and all these things, which would have caused hypoxemia, causing this cardiac issue. So that is one more part. So probably these are the possibilities at this stage.
Thank you, sir. So let's move on. Dr. Swapna.
So as we progressed, the next day MRI was done, and MRI showed T2 hyperintense lesions in the right side of the pons and medulla and middle cerebellar peduncle, and T2 isointense lesions in bilateral medial thalamus.
I would now request Dr. Gopinath to elaborate on the radiological findings and what is the possible differential with this clinical picture and these MRI images.
Actually, looking at the images, there is a dorsal brainstem and the middle cerebellar peduncle, and there is a T2 hyperintention. At this time, MS diffusion is very normal. I am not seeing any diffusion restriction. And the bilateral thalamic lesions also there. Since we are seeing the non-diffusion restricting dorsal brainstem, middle cerebellar peduncle involvement, and history of fever, and all the signs of infections are negative on CSF. So we initially thought of infection triggered syndrome, encephalitis syndrome / we can think of any ADEM related changes. First we thought. And our radiological diagnosis first, along with the clinical things, first we thought as a ADEM in this case.
Okay, sir.
Okay.
Thank you, sir.
So, as we progressed on day 1 of admission, her basic preliminary blood investigations were sent, which revealed a neutrophilic leukocytosis with normal hemoglobin and platelets, and CRP was elevated. With this, she was started on meropenem, vancomycin, acyclovir, and doxycycline were continued, and dengue, scrub typhus serology, and JE serology turned out negative. On day 2, since she was afebrile and hemodynamically stable, with blood cultures also being negative, antibiotics were de-escalated to ceftriaxone. And on day 3, her lower cranial nerve palsy persisted, and there was also new onset hemiparesis noted. And she was extubated on day 4, and considering the possibility of demyelination, she was also started on pulse methylprednisolone. At this point, after admission at KKCTH, we did not consider a CSF analysis initially because her prior CSF analysis was done only a day earlier at the referral hospital. And so with this investigations and MRI, we proceeded and we went on to start on pulse methylprednisolone on day 4 of admission. By day 5 to day 9, her hemiparesis started improving and she was able to tolerate oral feeds with some improvement in her cough and gag reflex as well. However, 6 days later, on day 10 of admission, she had new onset fever spikes with worsening of sensorium, progressive encephalopathy, and probable septic shock. The X-ray showed right lower zone infiltrates as well as left lower zone collapse. Meropenem and teicoplanin were added at this point, considering possible septic shock, and her GCs at this point was 13/15, with bilateral pupils still equal and reacting to light, and there was no new focal deficit noted, and her plantar was extensor. And she was hyperventilating with right lower lobe pneumonia and left lower zone collapse, probably aspiration related. And because of hyperventilation, she had to be intubated. And the repeat MRI brain done at this point in view of progressive encephalopathy showed new diffusion restricting lesions in the brainstem, cerebellar peduncles, and thalami. And she also had microabscesses noted in the pons, dentate nucleus, and cervicomedullary junction of the spinal cord.
Dr. Gopinath, sir, I would like to know your thoughts on how the MRI findings evolved in this case and what differentials to be considered with this worsening radiological changes.
Go to the previous slide, madam. Previous slide. Okay, in this slide, what we are seeing is a diffusion images. The diffusion here you can see the diffusion restriction. Okay, the diffusion restriction the left side and the middle cerebral peduncle is showing the diffusion restriction, and also the bilateral thalamic lesions also showing diffusion restriction. And lower down, what you are seeing is the flare images, the flare hyperintense areas. So, and coming to the next page. Here you can see the we are given the contrast. So here there is a peripheral rim enhancing lesions are there. So central diffusion restricting component with the peripheral rim enhancement. So it tells we are dealing with the micro abscesses. So in sense micro abscesses involving the brainstem and also the thalamus also showing the micro abscess. Not only the brainstem, upper spinal cord also here you can see the there is a involvement is there. So whenever you see the based on the previously the patient presented as a Adam-like features, and after a week the patient presented all the lesion turned out to be a multiple micro abscesses. So this is a very classical presentation of neuromyelitis. When looking at this case, the images after the second MR, after seeing the micro abscess, the previous presentation like Adam like presentation, and specifically the CSF here is negative. So the neuromyelitis on the thing, most of the time the early stage it won't secreted into the CSF. That's why the CSF will be negative most of the time. So when you're looking at the image and correlating the clinical things, so our diagnosis in this case is a neuromyelitis microabscesses.
Okay, sir.
Yes.
Thank you, sir.
So we progressed with CSF analysis for etiological diagnosis, and this is a comparison of CSF analysis which we did earlier at presentation, and now which shows the cell count which was initially 20 had increased to 41 with 20% neutrophils, and protein is also elevated at 436 milligrams per deciliter.
Dr. Ramesh, with two serial CSF analysis showing markedly elevated protein and a modest increase in cell count, what differentials to consider at this point in time?
So in this child who was initially started on steroids with the clinical worsening, and with this imaging feature suggestive of uh, worsening in the form of micro abscesses and in worsening CSF findings with increase in cell count, decrease in sugar, and increase in protein. Obviously, apart from what Sir told, one of the uncommon infections which we see is neuromyelitis. Other than that, in view of multisystemic involvement, tuberculosis also is a possibility, although there's only 20% neutrophils. With this, obviously, our CSF culture give a clue, or rather for other cultures would give a clue in this scenario.
Sorry for the disturbance.
So as we proceeded, our blood tracheal secretions and CSF all grew Burkholderia pseudomallei, and at this point, cotrimoxazole and doxycycline were added to meropenem. This is the blood culture report showing growth of Burkholderia pseudomallei, sensitive to ceftazidime, imipenem, meropenem, and cotrimoxazole.
Dr. Ramesh, to elaborate on the treatment plan and duration of treatment in a confirmed child with neuromyelitis.
So now that the blood culture is positive, I think CSF and ET also had Burkholderia pseudomallei. So the difference in treatment of melioidosis, whatever, even neuromyelitis and other foci of melioidosis, it is different from other forms of pyogenic infections in such a way that there are two phases. One is intensive phase followed by an eradication phase. So it is required because an intensive phase followed by eradication phase reduces the risk of relapse. So here, the treatment options and duration depends on the foci of infection. So, for example, in this case, with the neuromyelitis, what important thing we should consider is the initial intensive phase. It should be of true drugs followed by a suppressive or eradication phase. Whereas other foci of infections with isolated pneumonia or even an isolated bacteremia, even monotherapy with ceftazidime or meropenem might be sufficient. But here, I would not have added maybe doxycycline initially. I would have continued meropenem and added cotrimoxazole for the intensive phase with the clinical follow-up, and since both are susceptible.